Happy Tuesday, everyone. We will jump right in. Today, we are so grateful to have Dr. Ernst here from JBS International Inc., senior technical expert joining us from Wisconsin, and he's going to talk to us about naloxone, drug facts and controversy. So thank you for being here, Dr. Ernst. I will stop sharing and hand the screen sharing over to you.
Wonderful. Thank you. Aloha, everybody. Let me go ahead and pull up my presentation today.
Oh, Dr. Cohn's another rainbow.
All right. Can everybody see that?
Yes.
All right. Okay. So we're going to be talking about naloxone today. We're going to be talking about some of the challenges and some of the excitement that naloxone brings us. But before that, I just wanted to clarify, so I am not an MD, I'm not a prescriber. I'm a licensed clinician, but I work as a senior technical expert for JBS International. And JBS has the contract for the very large award to address opioids. It's through the RCOR program. And for those that are not familiar with RCOR, it stands for the World Community's Opioid Response Program. RCOR is a multi-year program that addresses barriers to treatment, specifically for opioids. It really supports the Health and Human Service goal to end the opioid epidemic. And it's funded by HRSA, the Health Resources and Services Administration. So that's a little bit of insight to you and a little bit of background for me. I've been in the field for many decades. I have worked with Hawaii before when I was the director for the Native American Center for Excellence, and we worked with the indigenous populations there to address behavioral health. That was years ago, but I still maintain contacts there and really enjoy my visits every time I can. Let's go ahead and begin. Let's see if this is going to move over for me. Well, it's not, so let me do something else. Let's try this one. There we go. All right, so we've already done the color, and thank you for those colors. Some were very creative. They did bring some smiles. When I was asked what my color was, I immediately thought of green because outside it is covered with snow. It is pure white. And green for me is a sign of spring and summer, followed by the colors of fall. So for today, I am green. All right, a little bit of background. Having served as a TEL for RCOR for the last 5 years, I've seen significant expansion of effective tools to address the epidemic. Those include medications for opioid use disorders. Those include a number of other practices. We recognize contingency management for some treatment has been effective, and many other types of practices. However, all of them remain underutilized. And that's been an issue and has been an issue for decades, the stigma associated with people with addiction. It is definitely out there. One of the important reasons is that stigma surrounds people with addiction. Even though medicine has long ago reached a consensus that addiction is a complex brain disorder with behavioral components. We understand that. We've been taught that in our classes. The public and even many healthcare practitioners and justice system practitioners as well continue to view it as a result of moral weakness and flawed character. Why do I say that? I say that because I have worked on this program for 5 years and have decades of experience before. people have stigma. The discipline they work in does not necessarily translate to the eradication of stigma or personal beliefs about the population served. When I worked clinical practice, I had clinicians, while I served as supervisor, I had clinicians tell me which populations they did not want to work with because they had issues with that particular population. And we still have the same challenge today. We have a stigma, but the issue today is very different, given the amount of overdose deaths that occur and the amount of losses that we have that are increasing significantly. And unfortunately, now we're at over 100,000 for the past couple of years. I remember years ago when we reached 50,000 losses for that year. I reflected on the total amount of losses we had from the Vietnam War was less than 60,000. And I thought that was amazing. And here we are close to well over 100,000. It's a sad state of affairs. So today what I'm going to do is I'm going to discuss naloxone. I'm going to speak from my years of experience and specifically from my experience working with grantees across the country who have been awarded an R-Corps grant to address the issues related to opioid use disorder. And we're going to talk about some of the misinformation. We're going to be talking about some of the myths, and we're going to be talking about some of the stigma attached that unfortunately prevents some life-saving that should happen out there in the field. And along the way, if you have any questions, please go ahead and put your questions in the chat, and we'll do our best to take note of that. Any questions that are not addressed today, if we run out of time, then I'll make sure that I get those questions answered so that your coordinator can send those to you. All right, so opioids, what are opioids? And the reason we're going to get into this is because I want to make sure we're all on the same page in terms of definition. So opioids are sedative narcotics used in medicine primarily as a pain relief. Opioids can repress the urge to breathe, and typically the overdose is that. Individuals has had enough of the opioid to cause them to stop breathing and places them at risk for death. Opioids are a class of drugs that are found naturally from the opium poppy plant. Opioids are made from the plant either directly or others like fentanyl are made in labs using the same chemical structure of those. What is Narcan, or what is naloxone? Naloxone hydrochloride, which is its generic name, is approved by the Food and Drug Administration, FDA, as a safe and effective treatment for opioid-related overdoses. That's what Narcan does. It doesn't do anything else. It blocks opioid receptors. It temporarily takes away the high, and it gives the person a chance to breathe. Generally, it works within 1 to 3 minutes, lasts 30 to 90 minutes. And that is subjective because individuals differ. The amount of drug that they've taken and the response their body has to the drug varies. So there's some variation in this, but this generally are the time limits within 1 to 3 minutes of beginning and lasting 30 to 90 minutes. Naloxone can neither be abused nor cause an overdose. And I'm saying this because I want everybody to really understand this. It is neither something that can be abused. It is neither something that can be used in the wrong way. It does not cause an overdose. It is not anything to be concerned about. And as a result, for somebody who's overdosed, you can give multiple applications of Narcan to that individual. And in fact, because of fentanyl, multiple applications is the norm. The only contraindication to what I'm saying is that if a person has a sensitivity, if somebody has an allergy to that particular medication. Naltrexone or naloxone is a medicine that can treat fentanyl overdose when given right away. It works by rapidly binding to the opioid receptors and blocking the effects of opioid drugs. Fentanyl, however, is stronger than other opioid drugs like morphine and heroin. And so it does require usually multiple doses of naloxone. People who are given naloxone should be monitored for up to those 30 or 90 minutes, up to 2 hours, many times, just to make sure that the last dose of naloxone still allows that individual to continue breathing. For individuals who would benefit from visuals, this is a visual. These are neurotransmitters. The opioid is the blue on top, and those blue were on the transmitters, covering the transmitters, causing the individual loss of breath to the extent that there was an overdose. And here comes the application of Narcan. And Narcan has the ability to remove those fentanyl or opioid, but most often it's the fentanyl they're dealing with today, and replace those with Narcan, giving the person an opportunity to breathe. So we're replacing one with the other, but it has to be done quickly, and you cannot wait for the application of Narcan because loss of breath, loss of oxygen obviously has some immediate consequences.
Dr. Ernst, how common is a naloxone allergy?
Very uncommon. In fact, I think that I have never heard of it in my career. And when I searched for it, I couldn't find information. I think it's placed there because there are allergies primarily for almost everything. I suspect that if I were to dig very deep, I would be able to find that some occurrence, but I have never heard of it, nor have any of my grantees ever reported it in the last 5 years. Great question.
Another question, if there were to be the rare allergy that you come across, is there anything they can do?
They would respond to that allergy as they would to anything else. EMS would be advised, of course, you're going to call 911 for an overdose, I assume, or first responders will be there with medical background, and they would know how to address an allergy.
Okay, thank you.
You're welcome. I'm going to refer to my slides on paper because the top of my screen is being blocked a little bit. So let's see this one. All right. We're going to get into a myth. So this is our first myth. And I wanted to make sure that I addressed it because unfortunately it's common. Naloxone, the myth is naloxone is ineffective in reversing fentanyl-involved overdoses. We know that's not true. However, there is that myth out there, and I've heard this from some of the grantees in their work in the field, is that some are using this as a reason not to administer naloxone if they feel that somebody has taken fentanyl. Naloxone is an opioid antagonist, reverses the effects of the fentanyl. However, fentanyl does act very, very fast, is much more powerful than heroin. And as a result, if somebody administers Narcan once and does not see an effect, maybe they feel that it is therefore ineffective on fentanyl, or they may administer it twice and again without an impact. You may have to administer it even more than twice for it to have an impact for somebody with fentanyl. It's important to remember that any overdose has to be responded to in a very timely manner. An overdose involving fentanyl or synthetic opioids can definitely require a larger dose. But I also want to get to what may be another reason for people to maintain this, and that's the issue of stigma. Let me pull in the next slide because that really addresses the issue as well. People who are addicted to drugs need tough love and harsh consequences. This is a myth. This, in addition to the myth prior to this, really links to the issue of stigma. Stigma can be used as a justification for the resistance of administering Narcan if the stigma relates to having issues with people who are doing alcohol and drugs. In this case, in this particular myth, the argument is that tough love is necessary for the person to learn by his or her mistakes. And that tough love can translate into some serious consequences. The issue is that stigma on the part of many people who see a patient's drug or alcohol problem as their fault oftentimes reject individuals, reject them oftentimes in treatment, refuse to administer naloxone. People showing signs of acute intoxication or withdrawal symptoms have in fact been expelled from emergency rooms or have been refused treatment. Beyond just impeding the provision or seeking of care, stigma may actually enhance or reinstate drug use, playing a key part in the vicious cycle that drives addicted people to continue using drugs. People with addiction internalize that stigma. They internalize the refusal and rejection, feeling shame, and eventually may refuse treatment, which obviously is not the goal that we want. Stigma is a huge issue. I would encourage everyone to take a look at what Shatterproof has done. If you go to shatterproof.org, you'll be able to see that they created a national survey to address the issue of stigma specific to substance use. They had more than 7,000 respondents from their survey. And they put in their questions, responses, the rate of responses, and they divided up their questions according to people who use drugs versus people who are in recovery from drugs. And not too surprisingly, many people did not have a difference in terms of their attitude. If they were against people who used drugs, many of them were also against people who were in recovery from using drugs as a moral failure. But I would take a look at Shatterproof because it also provides some excellent resources to address stigma, whether it's in a town hall meeting or whether it's with groups of members and committees. They have visuals, they have videos to address issues related to language. They have individuals on video who are in recovery and speak about their story. But definitely, I would spend some time on the Shatterproof website to learn more about this. All right, let's go to the next one. The overdose risk from accidentally inhaling or touching fentanyl. This is pretty big. This has been embraced by some groups, individuals, agencies, organizations as a reason not to administer Narcan for fear that any exposure, any skin exposure to fentanyl can cause an overdose. And I can understand the background for this. There has been misinformation over the previous few years that has addressed this. Fentanyl is, as we had discussed, is a prescription drug that's made and used legally and illegally. Like morphine, it's a medicine that is typically used to treat patients with severe pain. Tolerance can occur in an individual based on their need for higher or more frequent amounts of the drug. When prescribed by a doctor, fentanyl can be given as a shot. It can be given as a fentanyl patch. It can be put on a person's skin, or they have lozenges as well. In communities around the country, to get to the point of this slide, in communities around the country, stories and headlines were stoking fear for several years that fentanyl exposure through the skin could be fatal. In 2016, the Department of Enforcement Administration, DEA, warned that fentanyl can be absorbed through the skin or accidental inhalation of airborne powder could occur. They stated the onset of adverse health effects such as disorientation, coughing, sedation, respiratory distress, or cardiac arrest is very rapid and profound, usually occurring within minutes of exposure. This is from the DEA in 2016. The statement was accompanied by a video, and both the statement and the video were disseminated to law enforcement officials across the nation through channels such as the United States Department of Justice, the National Police Foundation, and that was in 2016. And then a similar warning was released from other agencies, including some by the CDC in 2019. Many of the reported fentanyl exposure incidents among police share the symptoms of a panic attack when they explored some of the behavior that was reported out there. However, there is still not a confirmed statement that I'm aware of that says that you cannot overdose from exposure. However, there are universities who have done their own research, such as UC Davis, who will state that there is no risk for exposure to an overdose when your skin is exposed. The American College of Toxicology and the American Academy of Clinical Toxicology issued a joint report asserting that the risk of fentanyl overdose via incidental transdermal exposure is extremely low. Well, all of these things still have not eradicated or minimized the concern that is out there. Mostly myth that an individual will overdose when exposed to the skin. So that has been a major challenge in many rural areas, especially when attitudes or perhaps misinformation prevent someone's use and application of Narcan. Obviously, it has resulted in death. But I did want to address that because that is out there. And if you go to certain YouTube, you can find a number of videos, I'm sure, that would show the arguments that you should refrain from using Narcan for that reason. Again, there is nothing out there that would suggest that is any great concern. There is information to suggest otherwise, but that is still out there.
Dr. Ernst, there's a question if you could define what extremely low risk means.
Yeah, unfortunately, there is no data on that statement. It was a statement put out by the American College of Medical Toxicology. And again, there is very little data out there because one, data coming from overdoses is very limited. We know even trying to gather data for the amount of Narcan that is being implemented across the country is very difficult. It's not accurately reported. So the answer to your question is that I can't tell you what that is. There's no data attached with that particular statement.
Thank you. And then back to the stigma slide. Sorry, we missed one question. There was a question if there were any comparison studies on stigma between provider stigma and the individuals who present with dependence.
Oh, that would be excellent. Yeah, that's a great question. I'm not aware of it, but that doesn't mean that the research isn't out there. So just to be clear on the question is whether or not there is a difference in terms of the amount of stigma identified and the level of need of the individual defined either by dependency, addiction, or not. Is that the question?
I believe so. Renata, is that the question? Is that what you're getting to?
It's a great question. And it wouldn't surprise me if there is some research out there. The issue with stigma is that there's so many variables that affect it. It could be the person's color of skin. It could be what they're wearing. It could be the time of day they're entering, whether they're coming at the end of the shift or a different shift. There are all kinds of variables that can come into to stigma. And oftentimes the stigma also is peer related. It depends perhaps in that unit or in that particular agency or from leadership. Attitudes carry down and they transfer to colleagues oftentimes. So the best way to respond is to provide a training, agency-wide training or broad training that allows as much participation from that agency and staff as possible so that people can work from the same page. Many of the, go ahead.
Sorry, she's saying that's not exactly what she's asking. Renata, do you want to unmute yourself?
Sure. Sorry. Hold on a second. I think we're gonna have problems with the muting. Can you hear me? Are you able to hear me?
Yep.
Okay, is there an echo?
No, it's good.
Oh, okay. So my question is, if we all have some level of stigma, which I probably would err on the side of believing that each of us has stigma of some sort because there's bias in each of us. It's just maybe some of us have a better way of lessening it than others maybe. But so what I want to know is if most providers present with stigma that's greater than the patient coming in that has the patient's own stigma, or if there are any studies that discuss the differences in it, or if the patient's stigma, that the patient that comes in that has their own stigma, which likely may have contributed to whatever their issues are, if those stigmas are in a greater amount or level than
yeah, I understand the question. I think it's a great question. I don't know that there's research. Yeah, I don't know that there's research out there. I would imagine there is. There is a great video that I will also send when I send my slide presentation. There's a great video of an emergency room physician and other physicians talking about the stigmas that they see. And there's individuals with lived experience who work in that facility who report that they have not let anybody know that they're in recovery because of the stigma in that facility. And I think it may be beneficial to take a look at that, because in a way it addresses the question that you pose. But thank you for raising that. And I agree with you. I think that stigma is, I think that personal bias is out there. But in this particular, with this particular topic, the personal bias, if it interferes with the administration of Narcan, which is only to save lives from an overdose, then obviously that's a huge consequence for the individual.
Thank you, Renata. And Leilani would like to point out back to the transdermal contact slide that harm reduction put out these informational videos showing them touching the fentanyl with no risk or overdose that we can look up later. It's a good resource.
Wonderful. Yeah, their harm reduction has come a long way. They have some excellent videos out there. They do have some research out there as well. They also provide a great deal of guidance in terms of protocol. So if anybody is looking for that. And most of the states, each of the states that I've worked with have a lead agency that is responsible for harm reduction messaging as well as resources. So you may want to check into that as well. All right, so here we are with a case study. And I just wanted to pose this out there. This is a case study individual that can present a challenge to us. She is not so atypical that probably all of us who have worked in the field do not recognize her. She's a woman in her late 20s, early 30s. Outreach workers are aware of for several weeks, but have not been able to meet with her. Like many of the women they encountered, she is unhoused, attached to possibly an abusive man, and she is using heroin. Unlike other women, however, she is 5 months pregnant. So the challenge is how to monitor this woman, how to prepare for the potential overdose. And I know that here in Madison, Wisconsin, if somebody is doing heroin, there's a strong risk attached to fentanyl being mixed with heroin. We just had 18 overdoses over the past weekend. So it's very challenging here. So the challenge here is how to prepare for yourself, for your agency, to best serve this individual, given her condition, given her setting, which is unhoused, given the relationship with a possibly abusive man, and that she's 5 months pregnant. What should be the considerations for preparing to work with this woman and hopefully preventing an overdose, but also preparing for an overdose with her? Any considerations you think about? And if you want to put that either in chat or if you want to open up your line and talk about it, either way. Any considerations?
Pain, emotional or physical pain, and what type of abuse is she being subjected to?
I would say probably domestic abuse. This was a case that was presented to me by a colleague.
Seeing if there's someone nearby that can hold the naloxone in case she needs it or needs access to it, quick access to it. Access to transportation and communication, cell phones, for example, access to prenatal care, being aware that we are all dealing with two addicted individuals here, the mother and the fetus. And where is she getting her heroin? And is the man also an addict?
Yeah, we don't know, but there's a strong likelihood that he is also using and perhaps supplying her. So access issues, a lot of access issues. The relationship is key. If he's an abusive man, there may be potential violence if he's nearby. Pregnancy is an issue. And if she is engaged in a potential treatment, or she is engaged in any type of prevention, then does that mean that that her partner, the man, would also be engaged? And if he refused, or if he was abusive to her for her engagement, how would you respond? Would you pull in a domestic violence department or staff for that? There's a lot of things going on here.
Yeah, so we have
Yeah.
sorry.
Go ahead.
We have a lot coming in. Providing access to housing, healthcare, clothing, food, human needs, supervision, domestic violence safe houses, an escape plan, prenatal care. What are other risk factors? Also, she may have distrust of institutions. In Hawaii, perhaps a counselor on the access line that can interview for help. Yeah, lots.
And then my next question is, out of all of these considerations, how many are realistic for your preparation? So does your agency, do your staff have access themselves to all of these that have been noted? And I think each one that's been noted is valuable and necessary.
Do we know if she has any other diagnosis?
No. We'll just assume that that her only issue at this point is the addiction and the abusive man, and being 5 months pregnant without any stable housing.
Be sure that the emergency services are prepared to respond quickly with her overdose.
We do know a little bit about overdoses at a national level. There was a study conducted by the Mortality Disparities in American Communities, MDAC, and they found, when they examined a nationally representative database of individuals who experienced opioid overdose, they found that emergency services were reported by 71% of the responses. So 71% of those individuals who had a reported overdose were involved with the emergency room. So we know that the emergency room is a huge player with this population. We know that 95% of the revival attempts were successful. So 95% of the individuals in this database were successful as a result of naloxone. And we know that reported overdose events happened to someone that the participant knew in 88% of the time. So for 88% of the time, these individuals who overdosed were with somebody they knew. And last, it says that 45% of the time they were with somebody that they knew that were not in the home of the participant. So not only did people, 88% of the time, did people use with somebody they knew and overdosed, but they were in a home, either their home or the participant's home, but but there was a significant amount that were not in a home when this happened.
Okay, so there's a big discussion in the chat. And thank you, Leilani, for that pregnancy and substance use toolkit. She left the link for us there.
Wonderful.
Someone asked if the EMTs and paramedics carry naloxone, which I believe they do here. And there was another question: are there drop centers that can provide these to addicts, and can these clinics be known as points of supply for naloxone? Or can private parties who work in this field carry the naloxone?
So the answer is yes, private parties can carry naloxone. I would encourage, frankly, many people to carry naloxone. I know that all of my colleagues carry naloxone. I carry it in my car as well as in my gym bag. And I also distribute naloxone to the church I attend and other places I think should have it. There's also something called Nalox box. A Nalox box is placed in high schools. It's placed in gas stations. It's placed in the waiting rooms of community clinics and the waiting rooms of jails upon reentry. A Nalox box has naloxone inside with the material so people can read it to understand how to administer that. And under our core, many of our grantees purchase Nalox boxes and set them up in those types of facilities. So that's available too. The Department of Health in Hawaii, I believe, also provides access to Narcan and will send a Narcan to agencies upon request. And my understanding is that in Hawaii that there is a standing order so that the public can purchase naloxone in pharmacies, those pharmacies that have accepted Narcan.
Is there a cost for that over the counter in the pharmacies?
My understanding in Hawaii there is. However, if you attend a Narcan training, typically, if you see a Narcan training that's being offered, and you could probably just go online and search a Narcan training. If you go to a Narcan training, they will give you Narcan for free.
Leilani has also posted a link in there where she said you can get it mailed to you. Thank you for that as well. Let's see, lots of questions. Dispenser. Someone said that there was a dispenser at the local farmers market.
Wonderful.
And Guam government is still debating on whether or not to make Narcan available outside of medical providers. And thanks for the link again. She's reposted it because it got lost in all the questions. Did I miss anyone's question? I think we got them all covered. Let's see.
Good. Then I want to move.
Okay.
I want to move to this last item. So we've been talking about some of the stigma and the challenge by stigma in terms of providing appropriate services, in this case, life-saving service to individuals who have overdosed. But I think we also need to think about after the overdose, because after the overdose is just as important as the overdose. And when you go to this, this is a guide for projects that are looking at developing post overdose responses, and it's called Pronto Projects. When you go to prontopostoverdose.org, you'll be able to see resources that I would encourage everyone to take a look at, whether you're part of a committee, whether you're part of an agency, whether you work for the state, whatever it might be. I think that you really need to take a look at what they're providing in terms of guidance to prepare for the post part of the overdose. So I wanted to make sure you had this. It wasn't specific at all to Narcan, but it's definitely specific to individuals who have another opportunity for treatment and behavioral change as a result of Narcan. So again, this is at prontopostoverdose.org. All right, that's about all I have for today. Are there any additional questions and comments?
So we have someone commented that it is $72 out of pocket covered by Medicaid with the prescription. And another person said about $80 and up out of pocket. And the one I had mentioned about being dispensed at the farmers market was being given out by the Hawaii Island Fentanyl Task Force this past weekend. And CVS has it on hand nationwide and can dispense same day. We have a question. Is Narcan only administered as a nasal spray, or are there other ways that it can be?
No, there are two ways to administer Narcan. Nasal is the easiest, but you can also you can also use a syringe for those people that are comfortable with that. But nasal, because it is much easier, much more user-friendly, nasal is typically the route that is most administered across the country. And note that Narcan does have an expiration date. So you do want to pay attention to that. I know that in some areas, when Narcan is expired, instead of disposing of those, that Narcan is given to some individuals in recovery, whether it's brought to an AA meeting or an NA meeting, and because frankly, many of those individuals will carry that Narcan if they can't find others. Just because of the expiration date is there does not mean is no longer effective, but that expiration date does serve a purpose. And lastly, there is something called Narcan Direct. And if you go to narcandirect.com, I'm aware that some of the grantees have used Narcan Direct as a source for Narcan. I'm not really familiar. I've never used it myself. I've not seen what the qualifications are, but if you're an agency or another body of members, you may be interested and may qualify for receiving it that way as well. So there's no question in my mind that Narcan is extremely important in our challenge with the opioid epidemic. It definitely affects the data in terms of the amount of people who survive an overdose. It would be much worse without Narcan as a tool for us in the field. So we want to do what we can to continue to expand Narcan out there, to continue to correct any misinformation and myths that are out there, whether it's by using some of the stigma tools from Shatterproof, or whether it's by having somebody in recovery who perhaps has overdosed and share his or her story. We just need to continue to move the needle in the right direction, to continue to save lives and give individuals another opportunity, while at the same time using appropriate prevention curriculum in schools and elsewhere so that people have appropriate decision-making. Drug use today, because of fentanyl and some of the others that are continuing to be made in the lab, is a huge threat to not only our children, but to the communities we live in. So it's really important that we use the effective and evidence-based tools that are available to us.
We have a few questions. Thank you, Dr.
Super. Yep.
Can you speak to the dosage of the Narcan, and whether it's different for nasal and injectable?
Well, let me see. May actually be able to show you the packet. Let's see. Many of my grantees have developed packets with the nasal spray in it, and where fentanyl test strips are legal, fentanyl test strips, they have a mask in it, they have the gloves in it, they have instructions about how to administer Narcan. With the nasal spray, you don't have to worry about dosage because you administer the whole thing. There is no partial application. You administer it all nasally. And then you wait for a response. And if you don't have the appropriate response, you administer a second one or a third one, depending on the case. So I'm not sure what the question about dosage is, but I do know that, but you don't have to worry about the dosage at all. It's a one-time use, and then you dispose of it.
And is there increased risk of death with each overdose if someone overdoses and
Great question. The answer is yes and no. Individuals who have overdosed have been shown that there is more likelihood for a return to drug use and an additional potential overdose. So we really want to try to prevent that initial overdose as much as possible. We want to encourage engagement in treatment. We want to encourage relationships and skill building so that they have opportunities for employment and school and stable relationships and stable housing. We want to do as much as possible before the overdose. And then with the overdose, it gives us an opportunity to work again with that individual.
Hi, Dr. Cohn, we see your hand up there. You can unmute yourself.
Thank you, Doctor. I just want to be clear about the doses for fentanyl. Sound like they're higher than for heroin or morphine, and I assume that it's going to take multiple doses, either nasally or injected, to treat a fentanyl overdose.
Typically, yes.
So carrying one dose of Narcan is not actually going to help somebody with a fentanyl overdose in a large.
I always have 3 with me.
Wow.
And even with heroin, it may take a second dose for an individual.
Thank you. That's very helpful.
Absolutely. That's a great beard, by the way.
Randy has pointed out that one person every 11 days dies here in Hawaii due to a fentanyl overdose. And Jennifer has seen Narcan firsthand save one of her parents.
I was on the phone with I have grantees in Hawaii, and I was on the phone with one of my grantees just before this call. And they told me that last night, 2 individuals had overdosed and survived because of Narcan that were administered by the police. And the police were given their Narcan by the R-Corps project. So we're seeing the impact. We're seeing the good outcomes that we're hoping to. We just need to get Narcan in more hands, and people need to be trained. So again, if you see a Narcan training, please attend. Or if you're working with your community clinic, your physician, please ask them for a Narcan training, and maybe they'll connect with the R-Corps grantees to get a Narcan training in your community, in your area.
Okay, I think, did we get all the questions answered? Let's see. What can you expect the patient to present after administering the Narcan? Combativeness by chance?
It really depends. It depends on the type of drug and amount of drug the individual's had. It depends on the overdose. whether somebody is entering an overdose and you're there immediately, or whether somebody has overdosed and it's taken minutes for somebody to come with Narcan. Because you can administer Narcan to the point where somebody goes into withdrawal. And so then you'll be seeing symptoms of withdrawal from the individual. And then attitude is typically a big thing. Individuals who experience overdose oftentimes are combative simply because they may not know where they're at. The setting doesn't make sense to them, and the situation may not make sense to them. Here in Wisconsin, we've implemented a warm handshake with a peer, somebody with lived experience, so that in 14 hospitals in the state of Wisconsin, all of their emergency rooms and the police and the sheriff's office, when they find an overdose is coming in, or when they find an overdose in the field, they have a phone number to contact to an agency that will connect them with a peer, somebody in recovery, and that peer will meet them in the emergency room or in the field if the person is refusing to be taken to an emergency room. And that person in recovery will then begin to dialogue with that person upon their recovery from that overdose immediately. And that begins a relationship. That relationship has been proven through data to increase the continuation of services to that individual, so that they no longer get lost out there in the system, but then in fact, they begin a relationship of recovery. So just something to keep in mind. Take advantage of the opportunity to link with that person, connect them with a peer, connect them with an agency, connect them with an outreach, but really take advantage of that opportunity. The window of opportunity is very, very slow and small.
Do you know if Narcan is effective for tranq or xylazine?
Any opioid is effective for any opioid that is out there.
Okay, thank you so much, Dr. Ernst. Very, very helpful. Leilani, did you want to unmute yourself here?
Yeah, I can. I have to go because I have a patient in 1 minute, but no, I would like to see a follow-up that is more attuned to like telling everyone exactly where to get it here, how to get it here, because a lot of the questions are going back and forth, and I have realized that there's a lot of people on the line. So there's like a lot of typing back and forth, and someone answers again, and then someone, but I'm seeing someone answering with wrong information, someone trying to answer with right information. As Echo just said, xylazine and tranq are not opiates. So no, it will not work on them because they are not opiates, and naloxone only works on opiates. So I feel like there's a lot more information to share. Unfortunately, we're out of time, but I would like to see a follow-up that's more specific to how folks can get what they need here locally.
I agree. Thanks. We can look into getting another session with some local resources to provide here in Hawaii.
Yeah, and the ARCOR grantees will have that information as well.
Yeah. Thank you, Dr. Ernst, and thank you everyone for staying on. Lala,
All right.
coming into the chat.
Thank you all for the invitation. Again, if you have any more questions that I need to address, I'll be glad to do that, but I'm glad you were able to stay for this and at least get some basic understanding of Narcan and some of the challenges that we have associated with it. Have a good day.
Well, hello, everyone.